Morning, Michael.
Good morning. How you doing, Dr. Karen?
Morning, Dr. Cheek. Good morning, Dr. Lang and Robinson.
Here, I'm present.
Mhm.
Good morning. It's glad to see everyone.
Same here. It's good to be seen. Mm.
Hope all of you are doing well.
We are. I happen to be down in Hilton Head, so I had a meeting down here, so I am joining from there. Uh,
Well, you
Weather's cleared up a little bit now. It was storming this morning, but it's clear now.
Michael, you can tell us you're working. That's okay.
No, I really am working, to be honest. Just to tell you how much I'm working, I didn't even bring a pair of shorts or a bathing suit at all.
Oh, wow.
They do have swimming pools that are open after hours, I would think.
Well, you're not gonna catch me in that. That's not gonna work for me.
Well, the weather's nicer in Atlanta than it was supposed to be. It was
Well, that's
planning,
good.
it's planning to rain today, but it hasn't, at least where I am, hasn't rained. And maybe it'll be nice tomorrow too.
Well, that will be good. Hopefully, Father's Day weekend would be nice.
Yeah, absolutely.
The nice thing about Father's Day when you get a little bit older is that a lot of times they're a grandfather too.
Yeah,
Mhm.
And that and grandchildren add to the fun.
sure.
As your kids get to be middle aged, they start to think of themselves as your parent. Watch out for this, watch out for that.
Yeah.
So I see Dr. Shin, Dr. Robinson. I think we lost the DPH team, but I'm sure they'll be back.
Oh,
Good afternoon, Dr. Rodriguez.
How are you today?
Good.
I'm having to do this from my phone today. I'm without a computer, so hopefully it'll work out okay.
Well, I hope you're in a nice place.
No, I'm in my office. It's just that I'm having computer issues.
I'm in my home office, which is a nice place. It's Dr. Toomey and the team.
Here we are.
Afternoon. I guess we're ready to call the order, Mr. Walker.
Well, thank you, sir. I'll be happy to. Dr. Cheek,
Present.
Dr. Curran,
Here,
Dr. Lane,
Present.
Dr. Mercer, Dr.
Uh,
Rodriguez. I'm
Excuse
sorry?
me, sir. Yeah, I believe Dr. Mercer will be joining us towards the end of the presentations. And for that reason, we were able to move the presentations a little bit from the original agenda so that she could hear the MCH updates.
Okay, great. We look forward to having her. Dr. Rodriguez,
Present.
Dr. Shin,
Present.
Dr. White, Dr. Jan. So we're missing two people. We expect Dr. Mercer to come. Okay, Mr. Chairman, you have your quorum. We can
thank
begin.
you. Before we get into old business, I just, there are so many changes going on at the federal level. I only wanted to remind us that, from my point of view, I guess 55 years in public health, I've never seen so many changes and proposed changes occurring all at once. And they occur from the point of view of recommendations, funding of partners, that a lot of changes, some of which are being contested. But given the importance of both relationships of the state health department, and as we'll see, the amount of funding coming from the federal government and some of the interactions with Medicaid as well, I think that, we're in for a less than predictable time in terms of how information is interpreted and how programs are funded with a lot of changes. And without saying anything about any of the changes, I just want to remind us that the changes are going to be causing a lot of interactions and changes at the state and local level, as well as the federal level. And you can tell, I guess, with my 55 years at CDC and universities, I see a lot of the changes occurring in all the places I've worked. Change is always difficult, particularly when you get older. But there's so many changes at once. It's very difficult to deal with. So having said that, do we have a motion for the adoption and approval of the minutes?
So move.
A second?
Second.
All in favor?
Aye.
Aye.
Dr. Toomey, it's all yours.
Thank you very much. And we have another action-packed agenda for you today. I did want to just briefly say that in response to your remarks, that we are monitoring what's happening at the federal level very, very closely. And to remain agile, to be able to ensure that we maintain all of our mission critical services across the state. But so far, we've been monitoring, and that impact, it has not yet really affected these programs yet. But as you said, we're waiting to see what comes out and when. But the good news is, although 51% plus of our budget is federal, 49% is from the state. And we had a very, very good year with our legislature this year. The governor and the legislators were extremely, extremely supportive of public health's work, particularly in the area of maternal and child health. And so what I'd like to do is really focus on that much of that work with Will Bell talking about, our CFO talking about our budget this year, and what we, now that the the budget is signed, the governor has signed off on it. We received the funding we had hoped we would receive. And later, Diane Durance talking about the perinatal work that we'll be doing, including an expansion of our very special and streamlined home visiting that has been already viewed to be not only effective, but one of the jewels of our public health work in the district. So why don't I turn it over to you, Will?
Good afternoon, Dr. Curran and board members. I think I've had the opportunity to meet all of you at this point, but just in case, my name is Will Bell and I'm the Chief Financial Officer for DPH. On May 9th, 2025, Governor Kemp signed House Bill 68, the FY26 Appropriations Act. This law provides a total of $37.8 billion in state funds to Georgia state government from July 1st, 2025 through June 30th of 2026. Over the next couple of slides, I'll provide a summary and highlights of DPH's state appropriations for the next fiscal year. Next slide, please. As a starting point for our FY26 budget, I always like to begin with a pie chart broken down by funding source of our current FY25 budget. DPH's appropriation across all funding sources for FY25 was $918 million. DPH is a predominantly federally funded agency with around half of our FY25 appropriation comprised of federal funding sources. As you can see on this green piece here, our federal funds comprise around 51% or $464.8 million of our overall budget, and around half of that is related to WIC, which is our Women, Infants, and Children program. As you'll recall, this program provides direct food benefits, nutrition assistance, breastfeeding support, and referrals to other social services. Other cost drivers within this category of funds are the Ryan White Part B program for HIV/AIDS, our Temporary Assistance for Needy Families Block Grant, or TANF, our Maternal and Child Health Services Block Grant, and our Preventive Health and Health Services Block Grant. Please note that our budget, as depicted on this pie chart, does not include federal funds for COVID-19. Just as a reminder, the most significant impact as it relates to our federal budget occurred in March 2025 when 11 COVID-19 funding sources were terminated. The amount of funding awarded to DPH was around $877.6 million. However, approximately $554 million was expensed, while the remaining $323.7 million was terminated. At this time, aside from COVID-19 related funding sources, minor federal grants have been impacted. It is important to acknowledge the unique uncertainty, as Dr. Toomey mentioned, of our federal funding situation, and that we are working through updated information on a daily basis. Moving on to our state general funds, which is what we'll focus on during the next couple of slides. Our state general funds comprise around 43% of our overall budget at around $400 million. And around half of those funds actually go to the county health departments in the form of general grant and aid. Other funds are around $22.6 million. An example of this type of fund is $12.6 million in restricted funds for immunizations for children enrolled in the Department of Community Health's Peach Care for Kids program. DPH also has two attached agencies, the Georgia Trauma Care Network Commission and the Brain and Spinal Injury Trust Fund Commission. As you can see, we have two trust funds reflected in our budget, the Trauma Care Trust Funds for the Trauma Care Network Commission and the Brain and Spinal Injury Trust Funds for the Brain and Spinal Injury Trust Fund Commission. Lastly, our tobacco settlement funds at around $14 million. The cost driver here, the predominant cost driver here, is our Cancer State Aid program. And just as a reminder, this program funds access to services for eligible patients diagnosed with cancer conditions conditions highly suspicious of cancer. Moving on to the next slide. This table represents a summary of our FY26 budget. The far left-hand column represents each of DPH's program budgets. The column titled Continuation Budget is DPH's FY25 base appropriation, which has a combined state general fund and tobacco settlement fund total of $400.2 million. Across all programs, DPH's FY26 budget represents an increase among state general funds and tobacco settlement funds of $3.8 million. bring the agency's new base budget to $404 million for FY26. Over the next couple of slides, I'll briefly highlight and provide background information on several items within DPH's FY26 appropriation. Next slide, please. This slide, as Dr. Toomey mentioned, focuses on our maternal and child health budget highlights for FY26. Before I get started, I just want to echo Dr. Toomey's comments around expressing our gratitude to the governor and the legislature for supporting additional funding for these items within DPH's budget. The first item is $3 million to provide home visiting in at-risk and underserved rural communities during pregnancy and early childhood to improve birth outcomes, reduce preterm deliveries, and decrease infant and maternal mortality. We see our home visiting program as a key strategy to decrease infant and maternal mortality and morbidity through clinical assessments for pregnancy and postpartum warning signs and symptoms, depression screening, and linkage to needed resources, including transportation, food, and safe housing. This budget item is an expansion of the $3.4 million from fiscal years 24 and 25 for a total of $6.4 million in state funds for DPH's perinatal home visiting program. Currently, this program is operating in 50 counties across 9 public health districts, and in FY26, DPH will add an additional 25 counties across 10 public health districts for a total of 75 counties. The next item is $778,239 in existing funds of $97,701 for total state funds around $900,000 for a cardiac obstetric program to increase access to maternal fetal medicine. This item will provide additional funding to Georgia's perinatal regionalization system. This system ensures that high-risk mothers and infants are delivered at appropriate facilities for better birth outcomes. In addition to the challenges caused by the closures of rural birthing units, 23% of pregnancy-related deaths were due to cardiovascular conditions, and 71% of those deaths were determined to be preventable. We view the perinatal regionalization system as another key strategy to decrease infant and maternal mortality and morbidity. And these funds will create a hub and spoke model to improve access to maternal fetal medicine specialty providers. This budget item will fund additional staff in 5 perinatal regions to provide scheduled services in regional locations via hub and spoke. These services include cardiac assessments such as echocardiograms, pregnancy ultrasounds, and high-risk prenatal care. Bottom line, these funds will improve access to services. It is also important to note that these state dollars specifically will draw down an additional $1.7 million in federal Medicaid funds for total funds of $2.6 million. The last item that I would like to highlight as it relates to our MCH program area for FY26 is $600,000 to support quality improvement at birthing facilities and additional funding to increase the number of birthing facilities with verified maternal and neonatal levels of care. As background on this budget item, levels of care provide clear guidelines that help hospitals accurately identify which patients they have resources to provide care for and which patients should be transferred to a facility with more intensive services. This funding is required to support the cost of contracts with the American Academy of Pediatrics and the Joint Commission to provide verification of level of care for facilities that provide specialty and subspecialty levels of care, such as our level 2 and 3 facilities. This funding is also required for 2 registered nurse positions to provide ongoing perinatal quality improvement training and support in rural facilities, with the prioritization being level 1 and level 2 facilities without those resources currently. And continued on the next slide, please. The next item is $437,000 for the cost of mailing low THC oil patient registry cards pursuant to SB 495 from the 2024 session. As background on this budget item, this legislation directed DPH to issue low THC oil cards to eligible individuals on a 5-year renewal basis and to deliver those cards via certified mail or secure electronic means. Prior to SB 495, cardholders picked up their cards at county health departments, which created a barrier to patients already dealing with severe medical conditions. Additionally, the fee for a low THC oil card was $25, and these revenues were retained by county health departments. To implement SB 495, DPH completed the following. First, we centralized and streamlined operations at the state office and made processes more efficient by shipping cards directly to patients or caregivers via certified mail, and this is where the cost comes in. Of the $437,000, around $367,000 is being utilized for shipping, and the remaining $70,000 is being utilized for a customer service representative to accommodate the increased workload of implementing this legislation. Secondly, we implemented an online payment portal so that customers can get these cards easily. A transaction fee and a payment processing fee is assessed to prospective cardholders, meaning that this portal does not present a cost to DPH. Lastly, we increased the fee for cards from $25 to $30, but with a 5-year renewal. DPH remits these funds to the Treasury, and this fee increase offsets the cost to implement SB 495, meaning that this legislation is budget neutral. The last item I'd like to highlight for FY26 budget is $1.2 million for one-time funding for improvements and renovations to district offices and public health laboratories statewide. DPH's 3 state-owned district office buildings in Albany, Rome, and Waycross were prioritized for DPH's FY26 capital budget. As an example of what is included within this budget item, facility condition assessments were done for each facility and identified items that were outdated and well beyond their useful life. An example of this is the fire control panel in our Albany district office. This equipment is 31 years old and has an effective useful life of 15 to 20 years. And so we'll be replacing that piece of equipment with this, with these capital funds. Another example is the fan coil units in our Albany and Waycross district offices. Those are around 35 years old, but have an effective useful life of 10 to 15 years. And so we'll also be replacing that equipment with these funds as well. That concludes my presentation as it relates to highlights for our FY26 budget, and I'll be happy to answer any questions.
So thank you, Mr. Bell. And first of all, congratulations to you and Dr. Toomey and others, and as well as Governor Kemp and the legislature for sustaining and doing selective increases in the state budget for this year. And it's particularly impressive in the area of maternal and infant mortality, advancing that important priority. So congratulations. And any comments or questions from anyone else? We have a fiscally shy board today. Yes, we're moving on to Dr. Drensick.
Well, thank you. Thanks, Dr. Curran, members of the board, Dr. Toomey. It's a pleasure to be here with you this afternoon to provide the EPI update. Can we go to the next slide, please? So over the last, several board meetings where I've presented, we've had the opportunity to talk about measles and about respiratory viruses. And believe it or not, we're going to do that again today. But with the view that they change frequently enough that it's really very important that we keep a close eye surveillance-wise on some of the patterns and also the molecular surveillance so that we are best poised to have sound scientific prevention measures. So let's see and review where we are in June now in regards to the measles outbreaks that are going on here in the US. And I also want to give us sort of a end of respiratory virus season snapshot as well. So next slide, please. So let's take a look at measles cases across the nation. As of last Friday, when CDC updates the weekly numbers, there were 1,168 cases of measles total across the US, which is actually double what it was since I presented to you 2 months ago about this. So from April to now, again, these number of cases actually doubled. So we're seeing measles cases all across the nation, and Texas also remains really the measles hotspot, if you will, as far as the number of cases. But the good news in regards to Texas is that their outbreak appears to be slowing down. They only reported a total of 2 cases all of last week, but they're up to about 744 cases total. So as you may recall from our previous board meeting, the Texas outbreak was driven by, international travel and subsequent rapid spread in a unvaccinated and under-vaccinated Mennonite communities in West Texas. And it lasted for months. And it primarily impacted school-age children, as you can see, for the even though the overall overarching number of measles cases nationally is the highest. It's in school-age children. That's driven by that Texas outbreak as well. I wanted to just highlight one other thing. If we look at the sort of national picture, so it's good news that the Texas outbreak is slowing. We have other outbreaks that are actually accelerating in parts of the country as well. The vast majority of our measles cases that we see nationally are among unvaccinated individuals. And again, so 95% of all cases are unvaccinated. So it underscores for us certainly the importance of vaccination. And we also, as you know, again, no vaccine is 100% effective in all cases. And the statistics have shown us over time that 2 doses of MMR vaccine should be 97% effective in preventing measles infections. And what we're seeing even now with these national measles cases, so of the 1168, 3% of them had 2 doses. So that there is your 3% there, and the 97% that were protected. So that's actually reassuring as well. We've had 3 deaths due to measles this year. As we know, it can be a very severe infection. This number has not changed since the last time we were here. 2 of them were in Texas, and 1 was an adult in New Mexico. Next slide, please. So I want to highlight what not a national problem, but an international problem in North America. There is also a huge ongoing measles outbreak in Ontario, Canada. And this one is even worse than our Texas outbreak. As of this week, they've had more than 2,000 cases. It began in late October of 2024, also driven by travel to another part of Canada, actually New Brunswick, and then subsequent spread in Mennonite community as well in southwestern Ontario. Look at this epi curve. It looks very much like the Texas one I showed you last time. It's just consistent rapid spread in an under-vaccinated community. So all of the orange bars you see on the right, the cases are all, again, unvaccinated, a typical pattern. What I wanted to highlight that I think is different about what's going on in Canada and very concerning is that in this outbreak, they've actually documented 40 measles cases in unvaccinated pregnant women. And of those 40, 6 of them actually resulted in congenital measles. So they transmitted measles infection to their newborn as well. And one of the babies actually was born prematurely, and also it turned out to be sadly a fatal case. So this again is just a very interesting and tragic situation because of the susceptibility to measles in an unvaccinated pregnant woman. And so it's very, very critical that pregnant women, prior to being pregnant, are up to date on vaccination, because they will not get vaccinated while they are pregnant. But I wanted to sort of highlight this scenario that's going on there. Here in the US, we've documented 2 pregnant women that have unvaccinated pregnant women that acquired measles infection. One of them resulted in congenital measles, and that was in Texas, and it was in March. So again, the numbers are a lot lower here, but again, it can show you if you've got a lot of unvaccinated individuals, you can have these very severe outcomes as well, which is what we would, certainly not want to see. Next slide, please. So let's look at us in Georgia. And again, luckily, this is, these are measles cases over the last 15 years. And, sort of luckily, even when we're looking at this year, we are not talking about, Ontario-like numbers, Texas-like numbers, but indeed, just like almost every other state in the nation, we have documented measles cases that have been related to international travel or travel, and were among unvaccinated families or unvaccinated persons in pockets that resulted in further spread. So let's just take a little more in-depth look at this year in Georgia. Next slide, please. So we have in January, we documented 3 measles cases. I told you about those during our April meeting. They were all in the same family. And again, they were all household members that lived together. They had all traveled together. It was within the United States. However, they were all unvaccinated and acquired measles and brought it back here to Georgia. We were fortunate that our investigation and contact tracing and prophylaxis that we were able to administer to anyone that was potentially exposed, that was susceptible, did not result in further spread and did not result in secondary cases or did not result in, sort of the explosive type outbreaks that we've seen in other states. However, since then, near the end of May and beginning of June, we actually documented a very similar situation. We documented 2 new cases of measles in Georgia. And again, these were, similar. They were family members that lived in the same household, one of whom had traveled internationally, and all were unvaccinated in the house and, brought it back as well and spread within the household setting. So we now have 5 measles cases, confirmed measles cases in Georgia. And this second situation with the 2 cases, again, the investigation and the incubation period is almost over. The ongoing investigation, it still exists, but we're very, very much nearing the end. And again, very resource intensive, rapid deployment of folks in our public health districts and our clinical partners to identify any potentially exposed individuals and be able to offer them Pro-Feed and then monitor them over the incubation period of 21 days. So hopefully we'll have good news about this particular outbreak as well. That's still winding down. So next slide, please. As we mentioned, we've got measles outbreaks all over the country. These are just ones that were documented in the last week. I wanted to just take a moment and highlight one of them that occurred in Colorado, because I think this could be a cautionary tale that could happen anywhere. So let's go to the next slide, and I'll tell you the story of how this Colorado outbreak unfolded. So this outbreak actually occurred in the Denver International Airport. I'll walk you through the top to begin with. A passenger that is a United States resident flew back from Istanbul, Turkey, and landed in Denver on May 13th. The individual was symptomatic on the plane. Entered the airport. It was late at night. He had a connecting flight not until the next morning. So took a shuttle, to an airport hotel, stayed in a hotel overnight, woke up early the next morning, took the hotel shuttle again back to the airport, and then hopped on a plane on the 14th and went to his final destination, which was in another state. So the repercussions of this airport measles situation are the following, which we can just follow the arrows down. On the flight itself, besides the index case, which is blocked off in red here, there were 5 people on this plane that actually got measles, 4 adults and 1 child. So that's just that first flight. And again, these are, it's an international flight. It's a longer flight. And again, interestingly, in a plane setting, certainly we focus risk and we think about risk. We know how contagious measles can be. We know it can linger in the air. We know it can linger on surfaces. We usually focus risk, with people that are very close to each other on a plane, simply because it's spread by respiratory droplets. But in this setting, these people were all over the plane. But in an international flight, people get up and walk around and move to the restrooms. And so again, here we have 5 people. All 5 of these individuals that are listed as getting measles from the flight are Colorado residents. So they landed in Denver because that's where their final destination was, and they live in Colorado. So 5 just from that flight alone. And then interestingly, remember the next morning he had gone through the airport to get to his next flight. 3 people that were in the airport, just in the airport while he walked through it, again, also were confirmed with measles infection. 3 adults. 2 of them, and 1 of them worked there, and 2 of them were just other travelers. These 3 also were Colorado residents as well. So they're kind of counted as Colorado cases. So all of this to say, this is unusual, but again, it highlights all of the patterns that we've been seeing with airport travel, international travel, under-vaccinated individuals, and again, the kind of unique situations about showing how contagious measles can really be, especially in a relatively closed setting like a plane. So because of this, again, let's go to the next slide. CDC, as of last week, sort of revamped some of their travel alerts and travel recommendations to say that because the risk of measles from international travel can be so high, and we're seeing these situations like this more and more, CDC is recommending that all U.S. residents that are traveling internationally, no matter where, to any destination, should be fully vaccinated against measles. The change is, it used to be if people were traveling internationally to places that had known measles outbreaks. Again, we've been seeing these international travel patterns for a long time, but now it's like, no matter where you're going, make sure you're vaccinated. And if you've got an infant under 1, make sure you get them that early dose as well. So again, just to kind of remind us about this potential risk as well. So next slide, please. So now we're going to shift gears off of measles, and I just want to do kind of an end of season respiratory virus, just a couple of minutes here. So as we are here in June, as we can expect, this graph shows us at the far right that all respiratory virus activity is minimal now in Georgia. Our big 3 are again flu, COVID, and RSV. So all 3 of them are really big, well below baseline, which is good news. Next slide, please. But one thing I wanted to highlight is a pattern that we've seen with COVID since the pandemic. So over all 5 years since we've had COVID, we've seen a pattern where we have seen waves or increases in the summer, usually in August, and then also post-holiday in January. So if you see these arrows here, this is, COVID activity over all 5 seasons. And you can see it's sort of got this dual, kind of double camel hump every year in August and then January. The big one, it was January of the Omicron wave. But again, so look at where we are on the far right. So here we are. There was, again, our January peak, which is in blue. So this was January of 25. Blue arrow, far right. Look how much lower it is, than many of the other, we certainly are seeing much lower activity, and we're been decreasing since then. But I think we just need to be poised and be aware and continue to do surveillance for, every time we've seen these spikes, there was a new variant that emerged or a new subvariant that emerged and spread. So actually, next slide, please. So are we going to see that this summer as well? Are we going to get our July, August wave? It's possible because the genomic surveillance for COVID has detected a newly emerging subvariant that spread pretty rapidly around many parts of the globe, over the last few months. And the World Health Organization last week actually designated this new subvariant, which is called NB181, to be a variant under monitoring, one to watch out for, because they saw a pretty rapid spread, particularly in China, India, Hong Kong as well. There have been a few cases here in the US, not enough to even sort of blip a percentage now yet of cases, but it takes a little while to ramp up, and the spread was so fast in some of these other countries. This is typical. We've seen this really every summer. So I just wanted to note that we may be dealing with this subvariant, NB181, to drive an increase. And that wouldn't be much different than any other summer that we've been dealing with COVID, but it just reminds us of some of the appropriate prevention measures. And certainly we have a lot more immunity to COVID now, over time than some of the earlier years of the pandemic. But I think we still can expect to see some of these seasonal patterns. And COVID it's not like it has completely disappeared, certainly. Next slide, please. The good news is this is the same graph I just showed you, but I added in the blue representing COVID deaths. So the good news is that even though, sort of ever since the COVID vaccine was implemented and widespread in its use, the number of deaths related to the number of cases is, much, much lower. So again, the impact of vaccine has really kept COVID deaths down, and we're at the lowest that we've ever been, due to existing immunity, existing population immunity, and vaccine as well. So that I think is also good news. Next slide, please. So really the last slide that I have is really kind of our overall take-home messages, which we've heard before. No matter what, even from week to week, month to month, season to season, infectious diseases change, their patterns change. It's good that we need to keep an eye on these so that the epidemiology and surveillance information really will point our way to whatever the most effective prevention and control recommendations are, whether it's to ensure vaccine before travel, or seeing what international travel can do, or to ensure that we are reaching out about the risk of measles in unvaccinated pregnant women. This is all the epi driving these recommendations. We're still seeing the same. Most measles outbreaks and cases in the US are related to international travel. The MMR vaccine remains the best protection against measles. And then, even though our, seasonal respiratory viruses like flu and RSV have ended, COVID has historically experienced summer waves due to the emergence of new variants. That is something that we should always keep an eye on. And when we think about, one of the prevention strategies for that, COVID vaccination still remains a key component in the prevention of severe outcomes. Not only COVID, for other the other respiratory viruses as well. So depending on risk, individuals at higher risk for complications, like those over the age of 65, other populations that may be at risk, again, have this, what they call or what they refer to, despite some of the confusing changes in CDC recommendations about vaccine, this shared clinical decision-making, which makes sense. Think about, whether a child at risk, a pregnant woman at risk, an individual that's over the age of 65 or who has immune compromise or underlying medical conditions. Talk to your healthcare provider about the importance and the benefit of getting a COVID vaccine if we have a summer wave. And I think that's it for me. Thanks so much.
Thanks, Dr. Drensick. A couple of comments before we open it. One is to say that we're really glad you're here. And in particular, you showing us and reminding us the importance of good surveillance to understand what's going on and what's going to happen. It's really the conscience and the guidepost for public health. And speaking of that, the CDC issued today the data on immunization of infants and young children from I think 2021 to 2023. And that went down from an average of 95% to 93%, which is quite a bit actually. And I think and this was before, that obviously the current administration, which can be characterized as, the leaders can be characterized as strong vaccine skeptics. So I think we're in for a time period where skepticism of vaccines could lead to even lower immunization rates unless we're careful. And that may give people more freedom, but I think it will inevitably lead to more outbreaks, as we've seen with measles in a lot of places. So good surveillance is going to mean, and response is going to be extremely important to avoid other circumstances. Now I've spoken enough. Any comments or questions from anyone else? Dr. Sheik.
Yes. I just wanted to say thank you, Dr. Drensick, for an excellent presentation again. But as we're doing surveillances of the measles, is it working like you've done in the past, where the person that's the initial case and those that are around them have to check in daily to report symptoms, and how is that going? Has that been a very positive? I know in the past most people have cooperated and have been willing to participate in these follow-up questions or check-in days. Is that still what's going on when we do identify a measles case?
Yes, thanks, Dr. Cheek. I appreciate the question. It's a good one. Indeed, it is. So what we do is identify, kind of in the first broad stroke, all of the potential individuals that may have been exposed to a measles case in, for example, a healthcare setting, just as an example. And then from that point, you narrow it down further to individuals that can either receive prophylaxis, either a MMR vaccine or or IG if they're susceptible. And we do that right away because there are short time frames for that, 72 hours for vaccine, 6 days for IG. And then any remaining individuals that are still susceptible, or even the ones that did receive the prophy, we enroll them in an automatic system that we've used for years for a variety of other of other communicable diseases. And yes, we educate them, and we check in with them every day electronically. And if they do, and they're, most importantly, they're advised if they have symptoms to call us, and not to show up at the ED or their pediatrician's office, without advice from a medical epi and figuring out to limit exposures. But yes, even in our several few cases that we had here in Georgia this year, we've had great cooperation. Again, from people that were potentially exposed as well, and I think that all of it has gone smoothly. So again, it's sort of where the unvaccinated people to begin with in these households where it spread, but we were able to contain it from spreading further.
Thank you for that update, and it's I'm delighted to hear that it's going well. So thank you.
Mr. Walker.
Thank you. Dr. Drinzik, thank you as well for a very good presentation. You made reference to WHO, the World Health Organization, in your presentation, and correct me if I'm wrong, did not the current administration make a decision or something for us to withdraw from the World Health Organization? And if I am correct in that, how does that change your strategy, if it does, with things that are coming up? Because you mentioned that, we may have a spike in COVID coming up and other types of communicable diseases that come out. I'm just concerned that if we isolate ourselves, that may be doing a little bit more harm than good for us from a public health standpoint. Could you comment on that, please?
Sure. Luckily, so the World Health Organization, as a global entity, continues its work and continues to again monitor these patterns over the globe as well. So we have access to this information, and again, it's primarily a coordinating entity to share information around countries. So again, whether again decisions are made about active participation in certain WHO committees or something like that, it doesn't really prevent us as a nation from taking advantage of hearing about these patterns and about the surveillance patterns and epi that we've talked about as well. But again, I think your point is well taken in the sense that it always shows that, again, we don't exist in an island, no matter what, in regards to infectious diseases and communicable diseases. They exist around the globe. And, as we saw with measles, many of them are just a plane ride away. So it's important to have as much information as possible that we have and we can see, sort of around the globe. And CDC does this as well. So I'll end my comments there.
So, Mr. Walker, let me add a little bit more to that. This has happened before. Once before, we withdrew from supporting WHO, and its support is largely in the form of dues, which is based a little bit on the GDP of a country. So the United States pays about 20% of the dues to WHO, and the loss of the CDC the U.S. government dues will cause a 20% decline in the operating income for WHO. The other thing is that the administration has withdrawn all the U.S. scientists and workers from WHO. And many people are in charge of programs or are working in programs, and in fact, even different nationalities have something to say about governance of WHO. And the U.S. usually has an assistant director general, but they've all been removed forcibly, if you will, by the administration. So the CDC people are all home now. And the lack of having Americans over there and the lack of money will be a sore point for the people who are still there. Now, the administration is doing this because of, I guess, partly to save money and partly feeling like China doesn't put enough money in and has too much to say. But of course, taking all your money out gives you less to say. So the overwhelming number of people in public health oppose that. So this is not a public health decision to take the money away. It's a decision based more on money and global politics, independent of health.
Yeah,
That isn't to say that the WHO is the most efficient, best run organization in the world, just like the United Nations isn't. But there's no other one.
right. I got you. Yeah. Point well taken. It's always better to affect change from inside out than from outside in, I would think. But that's a conversation for another day. Thank you.
Mr. Chairman, could I just make a quick comment? Because both your comment and Mr. Walker's made me think of some discussions we had recently, because I speak on a regular basis to the other health commissioners, particularly the one in Texas who is currently overseeing this very large outbreak. And I think what's also lost in this is not only the cost, the tremendous cost of the public health follow-up, and Sherry alluded to this in prior presentations about the staff time and effort and the hospital time and effort that goes into identifying those at risk and also being able to monitor them over time. But it's also the time and lost wages. Many of the parents have to stay home with their child, or they themselves need to be in isolation or quarantine. And all this is sort of not captured in normal cost benefit analyses as the indirect costs of particularly a massive outbreak like this. And I think that has to be on our radar as far as what public health impact is of vaccines. I mean, vaccines actually are extremely important, particularly when you have a workforce with people in the community who need to be continuing to work and without the ability for childcare in the home. And particularly when folks are also potentially contagious. And so I think these are all some of the discussions that should be generating more food for thought about some of our decision making.
Thank you, Dr. Toomey. Any other comments or questions? And we can turn to Diane Durance.
Hey, good afternoon, everyone. I'm Diane Durance, and I am the director of our Women, Children, and Nursing Services Division at the department that includes all of our maternal and child health programs. Thank you for the opportunity to present some information about a couple of our key initiatives this afternoon. Next slide, please. And I'll start with one that we're very excited about. This is related to our regional perinatal system in the state. Just some brief history and kind of information about the current structure. This system began in the early 70s with 3 centers in Atlanta, Augusta, and Columbus. Those were joined by a center in Macon and Savannah by the mid-70s, and then Albany by the early 90s. This system is in place to ensure that there's a mechanism, a safety net, if you would, in our state to ensure that high-risk mothers and infants are delivered at the appropriate facility, at the correct facility that has the capacity to provide the level of care that they need. Currently, there's some language in the Department of Community Health's Certificate of Need rules and regulations that references the perinatal services in the state, but it doesn't. There was no Georgia law or code that governed or about the coordination of the system or authorizing anyone to really make changes to the system. And essentially, the language that's in the Department of Community Health Certificate of Need section just really says that the hospitals that are designated will provide care and transport regardless of the ability to pay. But again, nothing really in place to make any kind of modifications to the system. The current system is the expectations and requirements for those 6 centers that are currently in place are outlined in DPH contracts and in a core requirements document. The DPH contracts, there are 2 with each of the 6 centers, 1 for maternal care, 1 for neonatal care. And then the core requirements document is the standard of care for perinatal services as outlined by AAP and ACOG currently. Next slide, please. The contracts that are in place are largely in place to coordinate the funding to each of the RPCs. So there's a combination of state and federal funding that each of them receive. There's about $1.5 million in state funding that is appropriated to our department. That is, in addition to that, there's $3.1 million Medicaid match funding that is applied from the Department of Community Health. So our department manages the contracts and the invoices and works with DCH on the match portion of that. There's additionally about $16 million that's appropriated directly from the Department of Community Health to each RPC directly, specifically for neonatal care and transport. Up until currently, from the early 90s until now, the distribution every year has been provided, of funding for these has been provided by an agency called the National Perinatal Information Center, NPIC for short. And each year, NPIC takes data from each of the facilities, and it's data for their patient volume and acuity, transport information, and uses a funding formula to divide the available funding out across the 6 facilities. So our part here at the Department of Public Health has been largely management of the contracts and establishing kind of a process for communication between the hospitals, but not really to make any kind of changes. Next slide, please. I wanted, over the next couple of slides, I wanted just to share what the population and kind of location of birthing facilities in the state, to give a sense of how the regions are set up right now. As you can see, we've got 67 birthing facilities in Georgia currently. About 43% of those are in the Atlanta region. You'll see that there's a level 1, 2, and 3 levels of care that's included here. That references the level of care established through the Department of Community Health Certificate of Need process. We have currently about 29 level 3 facilities in the state. The majority of those are in, about 65% of those are in the Atlanta region. So once you get south of the Atlanta region, lots, there's way fewer level 3 facilities. And in the Albany and Savannah region, the only level 3 facility in those 2 regions is the RPC. And we'll just say that the level of the level 3 level of care is the higher level of care for the most at-risk moms and babies. I also wanted to share just some additional information about some of the regional changes that's happened across these 6 regions since the early 90s, if you would. Just since even 2014, we've had 15 rural labor and delivery units that have closed. So just in 11 years, we've had that many close. And since the early 90s, it's been about 45 that have closed in total. So way fewer birthing facilities, and you can really tell that across outside of the Atlanta region. The greater number that have closed have been in the Augusta and the Macon regions. Next slide, please. And just a reference to the births in the different regions. Atlanta region is responsible for has about 61% of all the births in the state. During this 5-year period that's shown, there's just over 600,000 births for kind of an average of about 120,000 births a year. Next slide, please. And the percentage of births by payer. Across the board, in most of the regions, Medicaid accounted for the highest percentage of births by payer outside of Atlanta and Augusta, with the Albany region having the highest number of births that are covered by Medicaid. Next slide. Okay, so there was a 2-day strategic session that was held last September 2024, with leads from the regional perinatal centers. There was some legislative representation that participated. There were other agencies that participated from the Department of Community Health and Department of Behavioral Health and Disability. And this was really just a 2-day session to discuss the needs that are currently in place in the system, what's working, what's not, what's needed, and opportunities for the system going forward, what we need in a regional system in Georgia, from this point forward. This is largely since I mentioned that Albany was added in the early 90s. With that change, that was the last system that was added, the last facility that was added. The other thing that's remained relatively the same, at least for the last decade, has been funding. But the state has obviously changed and grown. We've had hospital closures. There's been things that's happened. So there was identified that, there was a need for legislation. That's what came out of the session from the participants. There was a need for legislation to provide more formal coordination, oversight, and monitoring of the system going forward, and strong support for the Department of Public Health to be provided the authority to make changes in the system when they're indicated. So House Bill 89 was introduced during this past legislative session, passed both houses and was signed into law on May the 1st. We're very excited about this legislation, as I believe all of the regional centers are. It establishes all of the things that came out of the session that we had last fall. First of all, an advisory committee that will make recommendations to our department commissioner, Dr. Toomey, about the addition, reduction, transition of centers in our state, and also to provide an estimated cost of what those recommendations would cost to implement. So it requires us every 4 years, beginning in July of 26, to provide a plan to the governor and legislative leads outlining system adequacy and identified needs. When changes are approved by the commissioner, then the department must submit a request for additional funding to the Office of Planning and Budgets, detailing the cost of what it would be to implement those changes. Next slide. So we are, as I said, very excited. The process is moving forward. We're already underway with advisory committee appointments, an anticipated first meeting in July next month. And our timeline for how this rolls forward in this next year is to complete an assessment of the regional system and complete that by March of 2026, with a formal kind of write-up and report to the commissioner by May of next year, and then final plan and recommendations to the governor and legislative leadership by the end of June. Should there be additional funding needs identified, our timeline would be to provide that to the Office of Planning and Budgets by the end of next July of 26. Next slide. This is just, I wanted to provide just a brief update on the status of our Maternal Mortality Review Committee. The committee has completed review for 2012 through 2022 cases. The most recent reports that have been published are listed. The committee was reformed with new leadership earlier this year. We have maintained, and the meetings are ongoing. The work is moving forward. We have maintained, plan to maintain our 5 full-time staff that do the bulk of the legwork for this process in terms of like requesting all the records, going through everything, compiling all the notes and everything for the committee to review and make those recommendations on. The case review for 2023 cases is underway, and we're expecting that to be completed by the end of this year. I did want to just kind of highlight, because Dr. Will and Dr. Toomey both mentioned home visiting. I don't have a slide for it, but just we are very excited about the opportunity that we have with our perinatal home visiting program. This was initially, the funding became available in July of 2023, but we didn't launch until October of that year, hiring staff and all of that. But since in the 20 months since the pilot has launched in the 50 counties that it's currently in place in, we have 582 patients that were enrolled at the end of May, and we have onboarded 46 home visiting staff. We're on target to have a pretty quick rollout in July with the next 25 sites, and they'll go through a period of training and onboarding staff and everything, and they'll launch, we expect, by October with service delivery. So our highlight right now is just to communicate this out more widely to OB practices, to get in those referrals for women who are pregnant and in the postpartum period. That's all I have. If there's any questions, I'll be glad to take those now.
Thank you very much, Diane. Any questions or comments?
I'd just like to commend Diane once again for her efforts and her work, being on one of the regional perinatal centers here in Macon. Over the years, one of the biggest concerns that we had was somewhat of lack of leadership and direction. And over the last few years, with Diane's leadership and Dr. Toomey's leadership, we've been able to see things moving in the right direction. We still have a lot of work that needs to be done, and that's basically highlighted by our infant mortality rate in the state of Georgia. But nonetheless, I think that we're moving in the right direction. I'm excited about this committee that's going to oversee the programs, because I think that's going to provide us with some leadership and some process in which we could move forward in making the changes that are required. So that, once again, thank you, Diane and Dr. Toomey.
Well, thank you for your service at the center and on the committees.
So Diane, I'm really impressed with how this is getting to be coordinated much, much better. You guys presented data in the past about the causes of higher maternal mortality in Georgia, and as I remember, quite a bit of the maternal mortality which is the first year of postpartum, was related to either cardiovascular type issues or substance abuse, which requires, therefore, the maternal centers to coordinate very carefully with the kinds of resources that are needed. Can you say anything about that?
Yes, I can. We agree with you, Dr. Kern. Will referenced some funding that's going to become available in July for some maternal regional clinics out of the RPCs. So in 5 of the areas outside of the Atlanta region, the other 5 will receive some funding. We expect that's going to be largely to support staff time to provide additional services in regional areas. We have at this point we've had discussions with 2 of those 5 facilities, so we're a little early in planning and expect they'll all have a bit of an individual take on how they roll those out. But we envision that being a way to connect women to more, to have access to perinatology providers, higher level ultrasounds without travel to the center, especially for women who require multiple visits. That was one thing that came out of the session and has been shared with directors over the years as, you know, just a need to have more services available for follow-up and outreach outside of the hospital walls, especially when you look at where hospitals have closed and the gaps between many of the counties and where providers are located. We do expect, as the committee, the advisory committee for the regional centers begins their work, another area that we do expect that is going to receive some attention and be prioritized for more support will be something similar for developmental clinics for NICU discharges, especially those infants who are born very low birth weight and require additional follow-up for some time.
Thank you. Any other comments or questions? Any general comments from the board or Dr. Toomey about anything else?
Just one thing, Mr. Chair, Dr. Chair, if you would let us know if there's some specific issues that are of particular interest to you. We've been trying to highlight those areas, like the MCH areas that are of particular interest to board members. And so please let me know if there's some things in advance of our next meeting in September, because we really like to focus on those programs and provide additional information for those programs that are of special interest or concern to all of you on the board.
Well, I think the issue of vaccine usage and vaccine acceptance will remain quite important. It has been already for the last few years, and I think keeping track of that will be very important to protect the public. And I'm particularly concerned about the vaccine market because of the recommendations for vaccines have usually come from the CDC generally, and they, you know, there's a proposed new regulatory system and a new approval system, which could result in less widespread recommendations, which changes the market, and more regulatory things, which makes it more expensive. So I'm a little worried that some insurance groups may back out of paying for vaccines. And I think keeping track of the various factors that influence vaccine coverage will be helpful in the future.
So consider it on the agenda, on our to-do list to continue to monitor, although we would be monitoring anyway, because it's clearly of concern for us, both how, you know, we have access to vaccines through our federal partners, but also how insurance companies are willing to pay for vaccines, because we do provide services as well to the rest of the state.
Yeah, I think that, you know, the president's budget, of course, it could get altered, but I think it may actually remove the vaccine program from the CDC and supplying to states. So I think part of the decreased funding to the states will be in specific areas like vaccines. Maybe not. I mean, it could change, but you know, the Congress has got a lot of other things on their mind.
I'll put this as an official to be continued discussion.
Are there any other comments about anything? I guess we need a call for adjournment then.
So move, Mr. Chairman.
Second.
All in favor?
Aye.
Aye.
See you guys September 9th, if not sooner.
All right.
Thank you. Have a great day.
Rest of your day.
Bye.